Common Factors, Initial Therapeutic Relationship, and REBT. Dr. Bruce Wampold, in an important article entitled, "How Important Are the Common Factors in Psychotherapy?" has written that common factors in psychotherapy are not just elements of psychotherapies shared by all psychotherapies, but together constitute a model that purportedly describes the actual mechanisms of change in psychotherapy. One such model is called the contextual model. The contextual model describes three pathways through which psychotherapy yields beneficial changes. Moreover, these pathways are the result of evolutionary changes that have created humans as social beings. Supposedly, psychotherapy is one way to bring about healing within a social context, and which goes beyond focusing on specific mental, emotional, and behavioral disorders or syndromes. The three pathways involve, in brief, the presence of a real relationship between therapist and client, the formation of expectations via explaining a disorder and the treatment involved in addressing the disorder, and engaging in activities, behaviors, or actions that promote health. Wampold has written that prior to these three mechanisms being implemented, a sound therapeutic relationship between the therapist and client must be created. Very quickly in the initial therapist-client session, the client determines whether the therapist can be trusted, is an expert, and will work to understand the client's problem and the context of the problem. The factors that contribute to the initial very quick determination of these attributes are multiple and include diverse factors such as how the therapist is dressed, articles in the office, and other features of the setting that are relevant to the client. However, there are factors that the client brings to the therapy session, such as the client's life experiences, expressed views and recommendations of significant others, cultural beliefs inherited by the client, and others. Among common factors, the therapeutic alliance has been studied the most. Wampold notes three components of the therapeutic alliance, namely, the bond between the therapist and client, agreement between the therapist and client about the goals of therapy, and agreement about the tasks, or the therapeutic moves within the psychotherapy. One interesting finding in common factors research is that the therapist's contribution to the therapeutic alliance was greater than the client contribution. In fact, the client's contribution did not predict the therapy outcome. Also, very interesting is that effective therapists, regardless of the model used and type of client treated, are better able of forming better therapeutic alliances. So, does REBT support the importance of a sound therapeutic alliance? First, Wampold himself found that the therapeutic alliance was as strong in cognitive behavioral models as it was in experiential and dynamic models. REBT may not embrace a strict linear process of first forming a strong therapeutic alliance, and only then should the therapist begin therapeutic interventions. In fact, as found in the common factors research, REBT holds that the therapy begins the moment the therapist and client meet, and that the curiosity and unconditional acceptance of the client exemplified by the therapist is fundamental to good outcomes. As Wampold noted, the therapeutic alliance is impacted by factors of the setting and expectations and cultural factors the client brings to the therapist-client relationship, and that the client determines in seconds whether the therapist is trustworthy or not. Thus, the therapeutic relationship in relationship to the initiation of treatment, if linear, is not a long process with a rigid demarcation between initial therapeutic alliance and treatment. This is consistent with the view within REBT that the therapeutic alliance is multifactorial, and among the factors is the initial empathy and curiosity of the therapist as well as the collaboration nature of the therapist-client relationship. Stated differently, therapeutic treatment is a factor of the initial therapeutic alliance, an alliance that evolves. Many clients in REBT state that the fact that treatment begins within the first session actually contributes to the client having hope about the outcome, especially in the context of a warm, supportive therapist who is deeply connected to the client through empathy and curiosity. What about the role of culture in REBT? The REBT therapist is not to act as the expert, but the learner about the cultural beliefs, values, and rituals important to the client. While REBT has an ideal vocabulary of emotions, This is to be set aside when the client refers to their emotional experiences in ways that deviate from the ideal vocabulary. At the level of cognition, which one generally thinks of as important in second-wave behavior models, such as REBT, one cognition, namely, the inferences are the attributions of meaning the client gives to events, situations, and situations in the life domains of the client, all the way up to attribution of meaning of life. In REBT, it is essential the therapist learn how, and to what, the client attributes meaning, much of which is culturally influenced. As Wampold states, cognitive behavioral models, or practitioners of these models, exhibit the importance of the initial therapeutic alliance. It is very much emphasized in REBT and is not found to be greater in other models than within REBT. I often hear my graduate students say that they have been taught that the outcome of therapy is all about the therapist-client relationship. This is a poor statement of common factors research that finds that there are essential components of the therapist-client relationship, not the presence of just any sort of relationship. It is important for the practitioners of any model to exhibit the necessary traits for a good outcome. We who are supervisors of psychotherapy students need to do a better job of being informed by common factors and the role of the therapist in the initial therapeutic alliance. It is imperative that we investigate, as best we can, outcome measures of therapeutic alliance in the very early part of therapy to help guide our supervisors so they can better improve their ability to form a sound therapeutic alliance, whatever their model.